and the unethical stuff that was done over the years, Nazi Germany stuff that goes historically about protection of human subjects and how we kind of really didn't do it very well for many years. Then it goes on into laws and rules, and it's really exciting. Really exciting stuff. My thought about that was that we can do that in here. If you want to come next week at 8:30, I'm feeling pretty confident that if you just sit here at your computer and knock it out, you could be done by 11:30. Unless you want to do it at home, I don't care. You tell me which would work better for you. I know you got a lot of other things on your plate to do, so if you'd rather just sit in here and just we'll do it as a group project, we could do that. It probably will take you the whole 3 hours. It's pretty long. Yeah. If you don't finish it, you can finish it later or whatever. So don't worry about any quiz next week because we just got to get this thing knocked out. Okay, it's good for like 5 years. So once it's done, you don't have to do it again. But you can't submit anything to the IRB when it comes time. And I couldn't find any other better place to do it or time to do it. Right? And you tell people, hey, you need to do this training, and they look at it and they're like, what? You know, because you spend your entire weekend doing it if you try to do it over the weekend. So, so I just decided last year to dedicate one class time to get this thing knocked out and done. So, and there's no option, you have to do it. So, so we'll do that next week. Then the following week, as the modules correspond to the weeks, and so the following week, they don't really. Okay, never mind.
I have a comment about doing it in class.
Okay.
Next week, just so everybody knows, is the week where our schedule changes, and we're going to be here till 9 o'clock at night.
Okay.
So if people want to do it at home, it would prevent us from being here for 12 hours, 13 hours.
That's fine, and as long as that following week you have a certificate to submit to me that you did it, because I'm not going to let you off the hook to do it and then it doesn't get done, right? So that's up to you. If you're going to wire, you're here till 9 o'clock.
Technology.
I think we have Cam moved to Thursday. Is that push tech back?
Yeah, it's lab stuff.
No,
Is that every week or?
Yeah, it's kind of, I don't know, we don't
It's
know
just
yet.
next week.
Next year when, it's just next week.
Probably.
We have chemistry got moved to Thursday from 4:15 to 6, and then technology is from 6 to 8:50.
So you know, if you go to the end of the syllabus, that Blackboard or that Canvas, builds a schedule for you at the end, where it says that the module reading quiz for module 4 is on the 21st, for module 5 is on the 28th, for module 6 is on the 5th. Do you need more than that as far as the schedule is concerned? Because, if you go to the end of every syllabus in Blackboard, in Canvas, all of the assignments should auto-populate a calendar for you. And then, if you go to the calendar in Canvas, it should all be there on your calendar.
You actually load things in the Canvas, whereas some of the instructors or professors will just basically put up a Word document. So Canvas, it can't populate all of that.
Okay. So you can see, like in the classes that I teach, are different colors and different things that are due on different days. So anyway.
So are you saying if we do the city thing together in here, is it something that it would be more beneficial to do as a group? Or are there testings, or is it just?
There's questions that you have to answer.
A lot of questions you have to answer as you go along.
So you read, and then there's questions.
It's like that
large
scale that takes.
So if you were to do it as a group, you would get through it much quicker than if you did it individually.
Okay.
So, that's up to you guys that you want to.
However you want to do it, I don't care. You guys can figure it out.
It just needs to be done. Yeah, but it's big. There's a lot of information you have to cover.
It is really long.
I saw we had that BSN competency survey piece of it, and there's also an MSN competency piece of it.
Yeah.
We do both?
Eventually.
Okay.
We'll talk about the other one later.
Okay.
After we get through some more of this stuff that we're going to do.
Okay.
I just want to get you up to speed as to what you should know at the graduate level with research, and so that's my only goal is to get you so that when we do get to a lot into the evidence-based practice stuff, well, that we, that you understand.
So if we start the city stuff at home, it can be started and stopped and
Oh, sure.
like done in small increments.
You can sign in, sign out, whatever. You go to the IRB, OSR, Office of something that sponsored research, Office of, just Google IRB in the UNF search thing. UNF IRB, it's the Office of Sponsored Research, something. Searching for the holy grail, which is the level 1 evidence. The level 1 evidence being your systematic reviews, meta-analyses, so for the most part. For level 2, you're talking about things like single RCTs or non-randomized trials, which is quasi-experimental design. In order to be experimental, there's certain things and factors and standards you have to meet in order to be a truly experimental design, right? So it requires randomization, right? It requires blinding usually to treatment and controls. Anyway, so then you start getting into more things like single prospective cohort studies. You'll find a lot of those in literature, especially when it starts looking at things like when you're looking at whether or not a particular treatment is effective, but you really don't need a control group to show a change. Okay. For example, one of the things that I was doing in the research that I was doing was I was looking at preoperative predictors of the problem of postoperative pain. So patients who can I predict preoperatively who's going to be a royal pain in the behind afterwards, right? With the difficult to control pain. And it's not that hard. Okay. There's really a really good study out there that was a cohort, single prospective cohort study. So what they looked at was they had the patients give, you know, the visual analog scale is, right, 0 to 100, it's usually like in millimeters. And you have the patient rank on there where they feel if 0 is none and 100 is the worst ever, just pick a point on there and then you measure it and that's your number for their score. It's a little bit more, the research shows that it's just a little bit more predictive than a 1 to 10 scale, than like an ordinal scale. So they used visual analog scale, and they had the patients, when they started their IV in pre-op, they tried to start the same gauge IV in the same place on every patient. And those, when they were successful, it was all for laparoscopic cholecystectomy. It was all for the same surgery. And so when they stuck them, they had them rank visual analog scale from 0 to 100, how painful, how much discomfort the IV start caused. And then, even weirder, they gave them 30 milligrams of propofol IV and had them rank where they, because anybody ever pushed propofol here before? Ever been, I have a few times. The gamut runs the entire, doesn't it? There are people that never say a word. You push, no lidocaine, no anything, you push like 150 milligrams of propofol and they never say a word. There are some people, you turn on the propofol infusion at 25 mics per kilo per minute, and they scream like you're cutting their arm off, right? So, when I had my colonoscopy, a little oversharing here, I was laying on my left side, my IV was in my hand was on top of the rail, and so there was no, this was Bowling River in and out, right? There's no Versed or fentanyl, because there's no reason why you're going to be here any longer. You have to have straight propofol, period. That's all you get. No lidocaine, I didn't get lidocaine. So CRNA pushes 70 milligrams of propofol, which I said, 70, that's kind of a lot. Last thing I remember. But apparently it wasn't. So it was there. So I remember, and the other thing I said was, that didn't hurt. I mean, it was crampy. It was like, it wasn't burn. People say sting or burn. It was not sting or burn. It was very dull. But it was like a crampy feeling, a dull, crampy feeling when they pushed it. But I remember because obviously I didn't have any Versed, so propofol is not anesthetic, right? So I just remember saying, that wasn't that bad, or that didn't hurt, or something like that. And then it's really, really bad when you wake up after it's all done and people are wiping copious amounts of lube off of your backside. That's just, okay, we're done. I feel violated. single cohort study. So anyway, I started talking about cohort study. So in this study, what they did is they had people measure on that visual analog scale. And then post-operatively, they tracked them to see their opioid usage and how much pain they complained of in their pain scales and stuff afterwards. And there was a direct correlation. Anyone that picked over 20 or over 2 data points in that, out of 100 on that visual analog scale, was 3.4 times more likely to complain of severe postoperative pain than people that selected less than 20. So there are predictors out there of people of problem postoperative pain. So take that to the bank with you. So when you start starting IVs on patients preoperatively and they scream bloody murder when you start their IV, they're probably going to need a little bit more narcotic than you maybe think they did. But if you're using narcotic by then, because God knows they're starting to do that too. So, yeah. So point. You got to drive me back to the point sometimes. I get really lost in the weeds. So I'm almost as bad as Dr. McDonough. By the way, one thing you can always do with Dr. McDonough is if he's got lectures, get him telling war stories, and then he'll run out of time, and then he won't be able to give you the test the following week. But I should have told you that before you had it in his class. It's a really successful strategy with him. So that you can understand as a single prospective cohort study, there's no need for a control group there, right? Make any sense to have a control group for that kind of a study? Because really all you're looking at is you're looking at a phenomenon, and so I randomize them into 2 groups. What am I randomizing them for? What am I controlling for? You know, they're all going to get an IV. It's not like I can do their anesthetic by hypnosis or something, right? You know, they're all getting an IV, so they're all going to get propofol. So randomization is it's a quasi-experimental design, but it's perfectly acceptable design for that study, right? So single case control studies, then you get down to cross-sectional studies, which cross-sectional just means that's just a snapshot, right? So in the time continuum, all you're looking at is a little slice of it, right? So, and then you get down to expert opinion, case reports, and that sort of stuff. So when you look at best evidence, you're looking at evidence that refers to research findings that are methodologically appropriate. You want rigor. You want them to actually be relevant. And they have to answer your question. So, question for you. I have some students who will remain nameless who have 3 or 4 RCTs in their evidence about ketamine, perioperative ketamine and postoperative pain, which there's a lot of research out there about using ketamine intraoperatively to decrease postoperative pain. There's also studies out there that show using IV Tylenol and then postoperatively controlling pain, right? So I got 3 or 4 RCTs about ketamine, 1 RCT about acetaminophen, and then in their results, they're saying that the combination of acetaminophen and ketamine is effective in controlling postoperative pain. Was that the research they read? No. So they read research that talked about the use of ketamine. They read research that talked about the use of acetaminophen. So can you say that A plus B equals C? So as much as you would like there to be something out there about, specifically about ketamine and acetaminophen together, looking at postoperative pain, if it's not there, it's not there, right? You can't invent it. You can't make it up. So as much as that may interest you as a topic, it's really not something that you can design an evidence-based practice intervention around if there's no evidence, right? And that's going to happen. Somebody, I promise you, in this group, you're going to have the best idea ever. You're going to be dancing, and then you're going to go look it up, and you're like, there's nothing there. And it happens. It happens to everybody. So, but we're getting better at helping people with project ideas.
Well, it's born out of experience with.
Oh God.
We know what the evidence is. We know once you hit a wall, we're not going to let you continue.
And there's a certain number of subjects in anesthesia, and I think we've probably hit every single one.
Yeah.
Anyway, pretty much off the bat, I can tell you whether or not there's anything like that. So there are a lot of challenges, obviously, in evidence-based practice. Research-related barriers, strong evidence, we talked about that. Nurse-related barriers, meaning inadequate skills locating and phrasing evidence. The average nurse that's out there, the average CRNA that's out there, if you ask them to go do a literature search, you might as well just ask them to go, I don't know, find a pot of gold at the end of the rainbow or something, because they're not going to be that successful, right? They have no skills, right? Unfortunately for us in our profession, we are judged as a group by the lowest common denominator. And there is, and you will run into them in clinical. They're out there. I'm just warning you. That the only thing they care about is going to work, doing their job, and going home. And oh, I need CEUs to renew my license. And oh, yeah, I need Class A and Class B credits to renew my certification. But above and beyond that, they're proud of the fact I have actually sat in the lounge and listened to a CRNA tell a student, I haven't cracked a textbook since I graduated 10 years ago. That's impressive. You're not taking care of me. So evidence, so you've got resistance. You will run into resistance trying to change practice. It just happens. Nobody wants to change. Nobody likes change. I remember back, once again, talking about both ways in the snow, stories. I remember when universal precautions were first rolled out. And everybody thought that was the dumbest thing they ever heard in their life. What do you mean I have to wear gloves to touch everybody, to touch anything? Nowadays, over time, everybody does it, right? Everybody wears gloves. Time out. Oh, surgeons were having none of that. This is bullshit. I'm not doing that. I'm crazy bullshit. You can't make me. Now, everybody does time out. So things change with time. They change. But sometimes it's just, there's a lead up to getting people to do it. Organizational barriers, financial support. Now, you could have the best idea in the world, but if it's going to cost the institution money, there's a likelihood it's probably not going to happen, right? Case in point is nurse residency programs. I had one of the DNP students who was an admin, nurse executive person. She was a CNO at a local hospital. Did this wonderful project about all of the evidence that shows that nurse residency programs improve competence in new graduates, right? And then she went to sell to administration. So, unfortunately, administration are these hospital administrators, right? They don't really understand the value of paying a nurse who's not productive, right? That doesn't make sense to them. It doesn't work in their little heads. How that's going to make things better. I don't understand. So we're paying somebody and they're not working properly. What's the point of that? So it was really hard to sell, getting that down the road, right? So if your project is great and all wonderful and you show there's a big difference, but the only problem is that now the facility has to buy, $10 million worth of equipment to make it happen, probably not going to happen. So you got to be realistic about it. That's good questions. So
Question.
sure.
So when we're looking at EBP and when we're getting out there and being in clinical settings, so is it that we're looking for a question, or should we be going at it whereas, okay, I have some knowledge of what the evidence is and what comes first?
You're looking for a problem,
Okay.
right? So what you're not, so another thing that seems to happen more than I care for is people who have a solution and there's no problem, right? If there's not a problem, your solution's not going to fix anything. You may want to change practice, but if in the end there are a select number of things that really the outcome's probably not going to be any better. You're not going to improve it at all. So, so what I've done, and it's 2 years in the making pretty much, is I've worn them down at my place of employment. And I've worn them down to the point where they're willing to work with student projects in the department, right? And they understand the difference between, so for the last couple of years, our biggest fight has been people trying to not understanding evidence-based practice, and then the clinical department people who we try to get involved in these projects try to turn them into research projects. Because we don't do research, right? I don't teach you how to do research. One thing, thank God, I don't have to teach you is methods of qualitative and methods of quantitative inquiry, right? I'm not teaching those classes, right? I barely stayed awake through them myself. So Anyway, so we're gonna talk about evidence-based practice, and you're gonna learn how to be an expert in evidence-based practice. So at Mayo, where I work, we actually have a doctoral research council, and there's about 20 doctorally prepared nurses that work at Mayo. So we all have this group, and we meet monthly, and we discuss different things. And one of the things that the pilot, I guess, first guinea pig, Alexis Johnson and that bunch in 2018 class, her group, they're looking at pre-warming and postoperative hypothermia. Mayo has, fortunately, all of the pre-warming equipment. For many, many years, the companies that come out with forced air warmers have had warmers for use preoperatively so that patients are normothermic when they get to the operating room and not cold when they get there, and you're not trying to make up the difference. The problem I found with those is, with about half the people you put them on, they're like turning it off or they're taking it off because it's too damn hot, right? But you get the idea. So they've got the equipment there, but nobody uses it. So they want a education and a utilization kind of to see if educating people about the importance of preventing hypothermia. The other part is that in orthopedic surgeons are crazy, by the way. Neurosurgeons are crazier, but there's a continuum of crazy. They're fairly up there. So they've got this big wild hair up their tail about forced air warming and infection. Because I don't know if you know it or not, but those forced air bear huggers blow germs all over the operating room. That's there. Now, the evidence is very weak. There is evidence out there. I don't believe it was statistically significant, the infection rate difference. There was a difference. It was there's a little moderate change, but it wasn't statistically significant in the one study I'm aware of, like say 4,000 a week, there might be more now. But they're convinced that forced air warmers cause infections. So that leaves you basically in a freezing cold operating room. If you've ever done orthopedic surgery on people, it's sometimes very challenging to find anywhere to put a blanket on them, right? And they get very, very cold. So if we can pre-warm them, maybe we can prevent some of that. Because then it comes back on us, because the skip measures whatever hypothermia, right? So if we take patients to the recovery room and the PACU charts their first temperature and it's below 35.5 Celsius, we don't get paid. Right? We've been for that. If it's Medicare, it's a Medicare patient, right? Just like somewhere in your notes, it has to chart that the patient's bed was at a 30-degree angle on the way to PACU. Did you know that? It's built into the Mayo. It's built into the CERN thing. It just comes up automatically. But you don't get paid for that either. It's really stupid, but it's one of the stupid things they do. So what we've done there is that we're going to start trying to bring at least a couple of groups over there to do evidence-based practice projects. The caveat is that a lot of times it's going to be stuff that they want done, but since you're going to be such a newbie at this and really have no idea what you're doing, it's perfectly acceptable evidence-based practice projects. It's just if someone's willing to do the footwork, I'm willing to get them through it over there. It's not a problem. And it's getting better. It's getting better as time goes by. Really, there's a lot. That class of 2017 had nothing but roadblocks the whole time. It was a mess the whole time, fighting people left and right, trying to get them to do stuff. But it's gotten a lot better. So we have a lot of different resources we can use for evidence-based practice. Most of it is the pre-appraised evidence, systematic reviews. There are a lot of systematic reviews. If you've ever been to Cochrane, the Cochrane website, and looked at stuff, there's a lot of systematic reviews in Cochrane. One of them is about, so Cochrane's in England. They got no dog in the fight, right? They're over there drinking tea and eating their finger sandwiches and Victoria sponges and whatever else they eat. And we're over here duking it out, the battle of CRNAs versus those other guys. And so they did a systematic review of outcomes in anesthesia based on provider. A couple years ago, came out probably 3 or 4 years ago or so, where they said, looking at all of the available evidence, there is no difference in outcome whether a nurse anesthetist or an anesthesiologist does an anesthetic. We went, woo, yay for us, yay for our side. They were like, it's crap. It's a systematic review. I don't know what to say a systematic review is crap. But yet they still managed to put their own twist on it to show that, well, because there wasn't a difference, was because they were around. And, which is not true, but, you know, they've got, delusional people have to tell themselves things in order to make themselves feel better about their life. So, anyway,
Were there any AAs in that research?
there's just not enough. The research with them is really, really shoddy because there's only like a couple thousand of them. Unfortunately, probably 1,000 of them in Florida, but they're just not, you know.
There's not a lot of evidence on AAs anyway, because they work underneath.
Anesthesiologists.
Anesthesiologists.
Who are the love children of anesthesiologists because they can control them, they can control everything they do, they can do all this. And so when they do screw up, which is often, it's often times. You gave what? Okay, no worries, we'll fix that. You know, you did what? Okay, no, we'll fix that. You know, so sort of stuff. Where if you did it, it's like, you know, call the police. You know. That's it that I would provide. So.
But does an MDA have to be in the room with them? They do not, right?
Okay.
Yeah.
You're confusing statues with reality.
Okay, right.
You can't confuse the two. If you look at the law, the way the law is written, the doc needs to be there all the time. In reality, they're not supervised any more than you are. But the docs will go to Tallahassee and they'll say, I'm there every second. Liar, liar, pants on fire. You know, whatever. But Florida is really an interesting animal in that Florida is one of only 5 states in this country that does not require sworn testimony in front of committees in the legislature, right? They don't, every 45 states, if you go to testify at a committee for any particular subject, you walk up and you say, you swear to tell the truth, the whole truth, nothing but the truth, so help God, or whatever, you know, and you say yes. Florida, it's not required. They don't do that. So you can sit up there and testify in front of a committee and lie all you want, because there's no perjury. You're not perjuring yourself because you didn't promise to tell the truth, right? So, and they go up there and they say that every single anesthetic that happens in Florida is under our direct supervision. And, you know, I mean, the things that they say are just amazing. That if we let CRNAs work independently, there'll be bodies stacked up in the corner like cordwood because they do nothing but kill people. You know, they're terrible, they're this, they're that. They have, their programs are online. I've heard that one before.
That we only need 1 year of experience.
Right, and or in that your program is only
because we all have only 1 year of experience.
yeah, right. They try to minimalize and trivialize everything that we do, and it is what it is. You know what? Every year, it's a marathon, not a sprint. Every year we get a little further. Every year we get a little further. You know, I mean, your lifetime, there'll be independent practice for CRNAs in Florida. It's just a matter of time. It's slowly eroding away that stranglehold that the Florida Medical Association, Florida Society of Anesthesiologists has on the legislature. You know, so that's why membership in your state and national association is so important. It really makes all the difference in the world. And it's another soapbox that I'm not going to get on, but really maintaining your membership in AANA. If there was not an AMA, there would still be doctors, and if there was not an ANA, there would still be nurses. If there was not an ANA, none of you would be sitting there right now. Absolutely, guarantee you, promise you, that without unity and the determination and the money and the tax and all that stuff that we have, that's the only reason why we're still here. Only reason. And you don't find CRNAs who say, well, I don't pay my dues because I don't know what an ANA does for me. Or maybe they didn't pay for your brain transplant. But anyway, speaking as a former president of the Florida Association of Nurse Anesthetists, a one and done president too, by the way. On the board. I'm not on the board. Not on the board. I was on the board for 7 years. I'm not on the board anymore. So Florida, the board of directors of Florida Association of Anesthetists. So we talked about systematic reviews, meta-analyses. Meta-analyses are, you know, they integrate findings across quantitative studies statistically. So you may or may not run into a meta-analysis. You might see as opposed to a synthesis that integrates and amplifies findings across quantitative studies. So in a systematic review, what you're looking at more than anything else is a synthesis of evidence, right? We're looking at what did the majority of the evidence say? Right? As opposed to a meta-analysis where they're actually doing the math. You know, like if you have a cohort study of 20 people looking at X, and you've got another cohort study somebody else published a year later that was 100 people that was the same subject, and another cohort study that was published 2 years later that was 150 people, they literally take them all, put them all together, and then redo the math, right? To see if there's a statistical significance across studies, right? So, you're not going to be doing systematic review. You're not going to be doing meta-analysis. That's like a group project, right? They're very intensive. Plus, AACN, CCNE doesn't allow that as a project anymore. They said no, can't do that. So, the thing about clinical practice guidelines is, and we're going to get into talking a lot about clinical practice guidelines in this class, because part of my job to socialize you from the role of nurse to doctorally prepared nurse anesthetist is to make you a little more cynical about and a little bit more suspicious about what you read. Up to this point, back when you got your CCRN and you were so excited and you were so happy with yourself, you started getting that heart in the lung thing, that journal that everybody just goes, you read this? You read those articles in there and you're like, wow, that's really cool. Wow, that's really great. Wow, that's really amazing. By the time you're done with me, you're going to look at it and you're going to say, why is the n so small? What the hell? Why are they using chi-square for paired data? That doesn't make any. This is crap. That's my goal with you, is that everything you read, now you're going to critique instead of approve just across the board without any thought, right? Because most nurses, if they read, well, if it's in the AANA journal, it's got to be correct, right? You should see some of the crap they publish in that journal. So there is no single guideline repository. Another reason why, what's really important is that I teach you how to effectively and efficiently search the literature to find what you need, right? Using things called Boolean operators, the various databases that are out there that are, oh yeah, my life is so exciting. A lot of the databases that are out there, the ones that you can and can't search, that are useful to search, Google and Wikipedia are not peer reviewed. Okay, so please don't talk. I've actually had people in role development use Wikipedia, what do you call it, references. So, there may be guidelines out there for things, but be skeptical about everything you read. So, because we're going to talk about clinical practice guidelines in this course, and I'm going to have you do a rapid critical appraisal of a selected clinical practice guideline. I'm going to let you pick the one you want to do, but you can't go out and pick your own. You have to pick one of the ones I have a list of, and I have very specific reason why there's a list of them that I give you. So there are a zillion models out there. When we get into evidence-based practice, we'll talk a little bit more about this, because I use Melnick's model, okay? Just because I find it to be the easiest one to use, in all honesty. Because it's a step-by-step process, easy to use. There are other ones out there. The Stetler model has been out there for research and evidence-based practice for years. The Iowa model is another one that you may hear about.
I'm sorry, I didn't hear which model he used.
Melnick.
Melnick. Oh, thanks.
Basically, this book.
Yeah, that's
Evidence-based practice in nursing and healthcare. And it literally walks you through all of the steps of the evidence-based practice process. And it's nearly foolproof. I'd like to say it wasn't. So it starts with step 0, 1, and 2, right? Getting started. And it literally talks you through finding the problem, designing the P-code question, all of that stuff. We're going to go through all that at some point. Eventually, we'll get through all of it. The Iowa model has been around for years, and a lot of people still use it. It's much more of a scientific model-based model. One of the funny things about nurse anesthesia that you're going to find over the years is there are really two camps. And there is the nursing-based nurse anesthesia camp, and there's the outside of nursing-based camp. Some of the outside of nursing-based camp people are pretty militant, anti-nursing, which doesn't really make any sense to me because they're nurses with a nursing, well, they have an undergraduate nursing degree, most of them. They have a nursing license in whatever state they're in. And, you know, so, but they're, oh, nursing is the worst, you know, our program is based in science and biology and blah, 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 blah. We give a doctor of nurse anesthesia practice, which nobody in the world has any idea except people in anesthesia what that means, right? You walk into some place that says kind of DNAP, it's like, what the hell's that? You know, I mean, mainstream nursing. We had to invent it because God forbid we give a nursing degree, right? We have to give a nursing. There's one that gives a doctor of anesthesia practice. What is that? So, with a DNP, everybody knows what that is. Everybody's aware of what that is. Someone's pointing at my room saying they're supposed to be in here, and they're not. So, I had last time I taught in this classroom, there was some guy whose class didn't start until noon or something, 11:45 maybe it was, who from 11:15. I mean, this class went to 11:30, so the last 15 minutes stood there in that window. I finally had to find out where he was from and talk to his chair because he was really bothering me. I said, can I help you with something? I'm waiting for you to leave my room. Remember when it's not your room. Okay? This is the school nursing, right? This is a nursing room. You're just using it, right? I'm waiting for you to get out of my room. Literally, I'm not so trying. I completely can't even pay attention because he's standing there. So, I could go over diffusion of innovations, but I know Dr. Robinson beat the snot out of that with you already, right? So just pull that one out of your stored place. So she loves diffusion of Roger's diffusion of innovations. She loves theory. When I was down in Miami, I taught theory. Mainly because, again, so I didn't have to subject the NC students to the faculty down there. But we actually had fun. We played Dead or Alive back then. Yeah, guess what? They're not doing that at all. All kinds of stuff. Yes. One of the funniest ones of all was someone gave their. So down there, you get your monitored when you give your lectures. Sometimes by senior faculty, they do evaluations. And Marie Louise Friedman, who was about 87 years old 20 years ago, she's still alive. It was sitting in the back of the room, and one of the students was giving their presentation, and they were talking about Martha Rogers. And they talked about Martha Rogers, how she drank a fifth of vodka every day and smoked like 2 packs of cigarettes a day and all this other stuff, right? And all this disparaging stuff. And she stood up and she said, Martha Rogers was a personal friend of mine. Well, died like 100 years ago. This is anyway, so okay, don't even go there. Because I got him. So my program director was Sandy Olin, right? Her program director was Helen Voss. Helen Voss was trained by Helen Lamb. Helen Lamb in St. Louis put Helen Voss on a train, sight unseen, sent her to North Carolina to start a program because that was what she was told to do. So, whatever. Lineage or whatever. So I had Helen Lamb on my side. So anyway, let's take 10 minutes or so. We'll come back and finish this up.
I went into the.
Let's go. So IRB here, and then it comes out Office of Research and Sponsored Programs, and then it should say something about attachments, needs, protocol.
Thank you.
See, okay, nope, that's fact. People only ask questions.
And you've got that loaded.
Yeah, that's on.
Oh, it says the report should be for 3 years, that was 5 years. Doesn't matter, you're still gonna be done, we had an air report expires.
The human subject research.
Yeah, social behavioral.
So that's where
So
it's at now.
cityprogram.org.
Which is cityprograms.org.
I think that's it, the city website, I think that's it.
You go to that and then register. Pretty much.
So it's an external page.
And we have to register, whereas he's
Yeah.
already on there.
Up to 8 or more hours.
It won't take it long.
It won't take that long, but it's lengthy.
The tops too.
If you do them both, it's really long.
Yeah. Let's do that.
Let's not do that.
Is that experience
That's
talking?
experience, oh yeah. I got done with it and I'm looking at it, I'm like, I think this is the wrong one.
Oh.
It's the wrong one. It was great. I turned to both ends, like, yes, look, I'm a really go-getter.
Did you graduate with Ashley this year?
No, Ashley's fine. Oh, DNP graduated.
Yeah, DMP.
Yeah.
I thought I saw pictures of you two. I was like,
Yeah.
he's loving Sam's.
Oh, he's, I'm.
So it's really a funny story. Pam Wolf is a dear friend of mine. We were stationed together back a million years ago when we were both captains, and she's the chief CRNA, and she's an 06. She's a full colonel. And so I said, do me a favor when he gets there, and just give him a whole bunch of crap and then tell him.
I'm pretty sure Ross was doing sport with her.
Dr.
Oh,
Hogan.
yeah?
Oh, yeah?
Yeah.
Yeah, I've known Pam forever. We were, one of my very first assignments, we were together when I was in the Air Force and she was in the Army. And I love her, she's great. And she's the chief CRNA there. She's pinned on 06 like 2 years ago.
Yeah.
So.
She doesn't, I mean, you couldn't even tell that when you're talking to her.
Yeah.
She's super nice.
She is. But it's funny because it's just the nature of the military. Eventually, it's like you're there long enough. It's like this this whole deal here. It's like if you're there long enough, I'm trying to find sign in my login. You know everybody. You know, walk through. I don't remember Salt Lake City or something. And it's like every 5 steps I ran into somebody I knew, and I was talking to them for 5 seconds. He's like, how do you know all these people? You just do.
It's the military. It's a small OR.
You just do.
Yeah, military.
And I'll tell you, you think that that's small, and I'll tell you, and I know everybody's said this to you a million times already, and once again, I'm lost in the weeds, but every day that you're in clinical, if you plan on staying in this area, every day is a job interview. You know, you got to look at it that way. I have had students who couldn't find jobs in the local area, and I can tell you exactly why. It's because all of their wounds were self-inflicted. You know, they couldn't figure out why nobody wanted them. I don't even want you to go. I'm waiting for you to graduate. Get the hell out. You know, I don't like you either. Why do you think anybody else does? You know, and it happens. You got to be on your toes because in this profession, I can tell you right now, if you told me that your great aunt was having surgery at Podunk Hospital in, you know, someplace in Kentucky, I may not know somebody that works there, but I can make maybe 1 or 2 phone calls, and I will probably be talking to a CRNA that works at that facility. Because that's the way, if you don't think it's a small world in anesthesia, I promise you it's a very small world. And especially when you are very connected, having been on, you know, state boards, having been on multiple ANA committees, having served as I'm an on-site reviewer for the Council on Accreditation. I'm out there, I talk to people, I see them all the time. And I'll tell you what, I can make a couple of phone calls and I promise you I'll be talking to somebody who can take care of that person's grandma for them, you know. It's not hard. It's really not for me. And so you got to be. I can't stress enough the fact that you got to be really careful. You know, and God knows I've had plenty of students that have had. I just don't remember what one.
Are you done?
No, it says CEs.
So University of North Florida. Okay, so that's the one. Group 2, social behavior research investigators and key personnel. Right? You see that one?
Yes.
That's the one they have to do. So part of what you're going to do and what you're going to need to do when you get to those clinical sites and you start getting some sort of a lay of the land of how things work is to ask people what things that they find, maybe that there are some uncertainties in their clinical practice, maybe some things that they wonder if doing something a different way might be a little bit more effective. Maybe if there's a burning question that they've been wanting to answer, but no one's really got the time or the energy to answer it. You know, a lot of DNP projects are born from people's curiosity about things, for example, like ketamine, you know, intravenous ketamine perioperatively and postoperative pain control. Multimodal anesthesia is on everybody's mind. Opiate-free anesthesia is going to be a big issue when you guys start getting out and doing your thing. There are a lot of places that are trying to do opiate-free anesthesia on patients, and I personally, so once again, you know, it's that whole mindset of changing the way people think, but in my, you know, used to use mask kids with halothane and, you know, all those other crazy things that we did. I did a C-section on a mask one time when I was in school. Good intubator. So I just did it on a mask. My instructor, who was these crusty old crabs, all taught me anesthesia, and there were these little old ladies that learned to drop ether. And the way you learn to drop ether is that they use rabbits, right? So you put the little ether cone by the rabbit, and you put a little ether on the rabbit, and when the rabbit gets a little goofy, they flip them over, right? When you can, because, you know, obviously a rabbit's not going to let you put them on their back unless they're half in the bag. So, you know, got to get the rabbit that far, because that was teaching you how to induce people with ether. And then they flip them over and they'd strap them down, and they would drop ether to learn the technique. They would drop the ether, have their shave the rabbit's chest and put their precordial stethoscope on the chest. I'm not making this shit. This is real. And they would have their precordial stethoscope in their ear, and they would learn the rhythm to drop, because the rabbit normally, when it's on its back, its legs are like this, and you had to get the rabbit's legs to relax all the way down and keep it alive. That's how they learned how to drop ether, and they all did it, right, back in the day. So they taught me. I was all these newfangled things like endotracheal tubes and stuff when I was in anesthesia school. Oh, you don't have any idea how awful it was when we were in school, you know. They would do prone cases, and they would put the agent that they were using, ether or whatever, in one of those, like if you ever watch cartoons, the bug sprayer with the big barrel thing, and as the patient would inhale, they'd go like this. Kid you not. They have drool and everything else up underneath that drip. So, yeah, they did a lot of crazy stuff before me. That was before me. But they were no nonsense, man. They didn't play. They told you to leave the bag alone because you're trying to get somebody back breathing. Because we didn't have all the end-tidal stuff like they have now. We had end-tidal CO2. That was pretty much all we had. And you're trying to get the patient back breathing on their own, and you go over reach the bag and they smack your hands. I told you not to touch that. You know, it's like, my program director, God, I was terrified of that. Oh my God, she just instilled fear in me. She talked to me, I think I was incontinent. We're friends now, but when I was a program director, she never failed to tell me what she felt like I needed to be doing. She was very free with advice. So anyway, we talked about asking questions that reflect uncertainties in clinical practice, and there's tons of them out there. You'll find stuff as you go along. You'll see things that you say, I wonder why they do that way. Why don't they do this? Or maybe, and you know, you can informally go look and see where the evidence points for different things. Search and assemble some evidence and appraise and synthesize the evidence. So synthesis seems to be, in evidence-based practice 1 and 2, one of the hardest things that people have. I try to wrap my mind around why it's hard, and I try to put myself in their shoes from their perspective, and it still doesn't work for me as to why it's so hard. But synthesis of the evidence is basically, if you're going to find 5 or 6 studies that show that doing X is more effective than doing Y, then you need to be able to tell me what those studies had in common, the findings that they had in common across the studies. You know, what are common themes that were in those studies that you read? And for some reason, people have a really hard time putting that together, and I'm not really sure why. Integrate the evidence with other sources. assess effectiveness. Again, a big, huge part of evidence-based practice is evaluation, right? Evaluation is super important, but you have to have a measurable outcome, right? So I'm gonna tell you right off the bat, the patient satisfaction is not a measurable outcome. Okay, it's not. And knowledge, beliefs, thoughts, in other words, you can think of perceptions, those are not outcomes, okay? Like, let's say you come to me and you say, I noticed that people aren't washing their hands or foaming appropriately at times or whatever. So I would like to put together an educational package for this particular anesthesia group about the importance of hand hygiene in anesthesia. Now, how many people here have been taught that you need to wash your hands in foam with every encounter that you do with a patient? How many people do it consistently every single time? If I teach you again, is the outcome going to change? Truth. Tell the truth. Is the outcome going to change? If I go over, spend an hour talking to you about the importance, the evils of germs, and the importance of washing your hands and foaming at appropriate intervals, a week later, do you think your practice is going to change? It doesn't. It's not evidence-based practice, right? It's based in evidence, but behavioral changes are not outcomes. Outcomes are things you can measure and things that you can see. Now, if you were looking at postoperative infection rates, or you were looking at length of stay, those are things you can measure, right? Tangible, solid things, not beliefs, perceptions, ideas, thoughts, any of that stuff, okay? Because I think hand washing is really important. I believe that it stops the spread of infection, you know? Do I always do it 100% of the time? No. And in studies that are out there which first off, I would never consent to be in a study where someone's got a camera pointing on me the entire time I'm doing anesthesia, counting the missed opportunities to foam or hand sanitize. It was like 60 to 70% of the opportunities among anesthesia providers were missed. Now, one of the things that I've said all along is, no matter what they've done in the operating room, everything from taking away our cute little cloth hats to making me wear a warm-up jacket, because God knows, you know, the fur is going to fall into the wound. It's going to jump off of my skin, over the drape, and into the wound. Because bacteria have feet and legs and pecs, and they're like little frogs, you know, they jump everywhere. So now I can see if I stood over the wound and went like that, you know, maybe something would happen. I went over the wound and went like this, you know. But me wearing a warm-up jacket makes no sense at all. But they were in, and those are their standards. You want to talk about clinical practice guidelines that are not based on any evidence. That's another story. Sorry, I'm not trying to pick on you. but anyway, over the years, there have been so many things that have changed. You know what has not changed? Is the basic bottom line infection rate. It has not changed, no matter what they've done. They've gone from betadine to Duraprep to Ioban to, I've seen it all, right, over my years in anesthesia. I've seen it all. And you know, that baseline stuff, infection rate doesn't change. And you know the one common denominator that's in that entire thing that nobody looks at that doesn't change anything that they've done? It's us, right? The OR, they'll change, they'll put on spacesuits, and they'll put on, you know, all this other stuff. But what is the one factor that nobody has changed our practice, or changed the practice of, that's one of those denominators of, you know, a part of the problem, whatever, you know, part of the operating room? It's us. We haven't changed anything. We still do everything the same way we always did. On the other side of the drape, they're trying to change everything all the time, and they can't figure out why the infection rate doesn't change, but nobody looks on our side of the drape to see if it's us, right? That has anything to do with it. Am I right? Nothing really changes. You know? I worked in a hospital for 6 years where we home laundered our own scrubs, anesthesia. We didn't they weren't going to give us, they didn't give us scrubs. We couldn't go in and change into scrubs. Those were for the physicians, right? They issued us scrubs. The CRNAs and the nurses got, you know, they were ugly too. They were like this really ugly blue color, but not like a nice blue, like a bright, it was ugly. I like this color, like a purpley blue. It was like periwinkle or something. So that was great.
Can't be worse
So-
than Maryland's pink ones.
Yeah, true. But we home laundered. I wore those scrubs to work. I went in, did my job, wore them home, right? Unless they were soiled or something happened. Guess what? Our infection rate was no worse than anywhere else. Doesn't matter. We're not in the operating room. Our hands are not in the wound, you know? I'm not part of the problem, right? Oh, maybe I am. Who knows? But anyway, so the dreaded PICO. When the time comes, we're going to start talking about PICO questions. And PICO questions are always in the form of a question. Okay, so when you send something to me, I want always, 100% of the time, across the board, regardless, in the form of a question. I want your question to start with do, not in. Okay? Do patients who have X, which is the intervention, compared to patients who do not have that intervention, have better outcomes, have less whatever, have more something else, have whatever. It's a pretty simple format. T is pretty much an option. Unless you've got a really good reason to use T, if time matters, time's okay. Because over 3 months, then if you say over a 3-month period of time, I'm going to ask you why 3? Why not 4? Why not 2? You know, what difference does 3 months make? Now, if it's something that takes 3 months to happen, that's another story, right? So, but when we get to PICO questions, we're going to talk about being very specific, because one of the things that's important about a PICO question is that when somebody reads it, there's nothing in that PICO question that is left open for subjective interpretation. When I say that, what I say is I used to have you guys do something called concept analysis, and it's a little bit more of a PhD, researchy kind of touchy-feely thing, concept analysis. But what it is it's a process that helps you get to the point of what you're trying to say. And one of the things that's in that book about concept analysis is to have everybody close their eyes and imagine a cup. So everybody sits there with their eyes closed, they're imagining cups. And so if I said to you, imagine a cup, what would a cup look like to you? Anybody, what would it look like?
Yeah, Dixie cup.
Okay, Dixie cup. Was anybody else thinking Dixie cup?
Coffee cup.
Coffee cup. Solo cup. Teacup, anything like that. What about like a golf cup, like, you know, you cut into the cup? Nobody was thinking about that, were they? How about the cup of a bra or a brassiere? Anybody think about that? No, right? So if I say cup, do you see how that can be subjectively interpreted by people as different things? We're not doing that, right? We want whatever you say, that if every single person in this room reads what you say, they know it to mean what it is that you mean it to mean, right? So that's why it takes so long to get these PICO questions down, why we work so long on them in evidence-based practice 1. And trust me, it's going to be like, we're working on these things for like a month, getting them straight. So, and then that's your first experience and subjected for the first time at great length to Dr. McCarthy. So, anyway, so, so, quality, magnitude, all those things matter. How precise is the estimate of effects? All of those things are those research-related things that you have to be able to do. You have to be able to tell me. You have to be able to say that I read this study, here's my rapid critical appraisal, here's what I found good about it, here's what I found bad about it, here's what they could have done better, here are limitations to the study. All that stuff matters. Because like I said, if you use that as part of evidence in a talk you give and you stand up in front of a whole bunch of people and say that, and someone walks up to you and say, I can't believe you used, you know, Joe Blow's study, that's the worst one I ever read, it's crap, it's got this, it's got that, it's a da-da-da-da-da, you just like, right, just going, you're in a death spiral on the way out the door. So, integrating evidence-based practice into research into clinical practice, I mean, is dicey at best at times. there are people, a lot of times, CRNAs in general, they look at integrating evidence-based practice into clinical practice as more work for them to do, right? Or an additional step they have to take. They don't, they don't necessarily, they're not necessarily bought into it from the standpoint of me saying that it's a hard sell. I'm telling you, there's still more than not people out there who honestly feel that their part of the job is over when they turn them over after they give report in PACU or after they give report in the ICU. That really whatever they did is immaterial, and it's so far from the truth. What you did is not immaterial, and you're going to start getting judged on it in your career and in your lifetime. They're going to start judging your outcomes and measuring your outcomes, because there are going to be insurance companies, possibly even Medicare and Medicaid services, that you're going to have a score based on the outcomes of your work. And you may or may not get blackballed by an insurance company if your outcomes are bad, as a routine. Now, we're not talking a single outcome. We're talking an aggregated number of outcomes. But unfortunately, the way big data is, and the way that they can assimilate and analyze data, if for some reason your patients seem to have a 15% higher incidence of postoperative nausea and vomiting than everybody else's, that could be a problem, right? So that's why evidence-based practice, especially in your career, maybe not so much in my career, because I'm thinking I'm on kind of the backside of the usefulness curve at this point. I'm not planning on doing this for about another 10 years, and then I'm out the door. So, but for you, it's a different story. There will be a time in your career when you will be rated and you will be assessed and you will be graded on your outcomes. And so you really need to be thinking from that perspective, from the very beginning of anesthesia school, from the perspective of what I do in the operating room matters, makes a difference as to this person's outcomes, as far as, are you using an evidence-based practice approach to postoperative nausea and vomiting prophylaxis? Mayo, it drives me nuts. All they do is they look at PONV in the PACU, and they look at who the primary anesthesia provider was, and they determine a monthly rating of PONV. It doesn't matter if I spent every day doing GYN laparoscopic surgery on young females who hit every single PONV, or I'm doing bunions on 90-year-olds who never puke, right? Old people don't puke as a rule, right? All I get is this raw percentage. Last month, your PONV rate was 32%. Not stratified, there's no controls, there's no anything. It's like, please stop sending this to me because this is absolutely useless data. Well, I started a firestorm when I said that. I don't want it. I don't need to see it because it's non-scientific. It means nothing, right? I'm not full-time, I'm part-time. I'm only there 1 or 2 days a week, right? I may be due, because it's Mayo, you can, in the time it would take a surgeon at any other hospital to do 3 procedures is pretty much the time it takes to do 1 at Mayo for the most part. So I maybe do 2 cases, maybe 3 cases a day, if that many, and so I maybe do 15, 20 cases a month, as opposed to a staff CRNA there that does 100. And if I'm in a room that has a high likelihood of people throwing up, ENT, that's a big one. One of the things about doing septoplasties, rhinoplasties, and all that other stuff is the head is slightly elevated. They're up there digging around in their schnoz, doing all kinds of, and that blood is just running back down. You don't see it, but it's running back down. And you notice, I'm sure you guys are like experts at anatomy now, because the trachea is in front of the esophagus, right? That esophagus is just sitting there, and that blood's just running down, and blood anywhere but in the bloodstream is irritating, right? Brain tissue, because you bleed in your head, you're pretty much screwed. You have stomach. If you have a lot of blood in your stomach, what's the first thing you do? You throw up. Your body gets rid of it. I can't control that. I can suction them out. I put an OG tube down them. I try to suck them out. I try to do the best I can. But a lot of times, long 2-3 hour long septorhinoplasty type deals, they puke. It's just unfortunate that there's blood, and it's blood when they throw up, and then they feel better. It's gone, and they feel better, right? But then that's going to be held against me, where I could have been doing bunions all day long, and they don't throw up. you know? So it's totally non-scientific. But anyway, you need to be thinking more than just keeping them alive to pack you, right? Although the other day I was, by the time I got to pack, it's like, oh, Jesus. This guy, he was 85 years old, inguinal hernia repair. I said, okay, cool. INR 2.1, not so cool. Yeah, it's easier to make a list of what was wrong with him. So he's complaining of abdominal pain in the holding area. They had admitted him the night before with a hernia. Well, 85-year-olds don't get inguinal hernias just because they get inguinal hernia. I mean, something has to have pushed it through, right? It just doesn't happen. They're not like working out, right, usually. So, suspect. So he's got this, all over his belly, he's got this just generalized kind of guarded pain all over his stomach. So Dr. McLaughlin, one of the general surgeons, she says, I'm going to do a diagnostic laparoscopy just to see what's going on. No scans, no nothing, nobody did anything. Got admitted the night before for pain in his groin. The resident tried to reduce his hernia in the ER unsuccessfully. They admitted it. Does this laparoscopy, she goes in there. When they were trying to reduce his hernia, they perfed him. He was perforated. So he's got a belly full of crap, right, in there. So now we're an outpatient. We're an outpatient. We're doing a hernia. No, we're doing a laparotomy. We did the laparoscopy first. You know, the old, oh shit, you know, from her. And I'm like, great. That's just for her to even say that. It's bad, right? She doesn't even blink. You can't knock this woman off her game to save her life. She does not get mad. So she's in there and she's looking and she's like, oh shit. So I got no stroke volume variability. This guy's 85 years old. He's got an INR of 2.1. I got no blood. I got no type and cross match. I got nothing. I've got no A-line. I've got no second IV because it was a hernia repair. We're doing a hernia. So we ended up doing a laparotomy, a hemicolectomy, bunch of other stuff, and I got him to pack you a month, and he was good. But if I had known that we were going to do all that stuff, I would have had FlowTrack. I would have had the other stuff in there, but it all kind of, you know, it snowballs sometimes. You work at a level 1 trauma center, you know how it snowballs.
It does that.
Why I choose not to work at a level 1 trauma center anymore, because the excitement phase of anesthesia for me is already, it's ended. I don't like being excited anymore.
Oh shit from the other side of the bridge,
Never good.
never know. In my experience.
Yeah. So one of the cells is to trying to get people to integrate evidence-based practice into their own practice, and by looking at it from a perspective of the patient's values and preferences. Sometimes evidence-based practice doesn't always gel with the patient's preferences or values. You work around that, and you look at the evidence from the qualitative research. Dr. Osterbrink and I got into it because I basically said qualitative research was crap, but I really didn't say it exactly that way. For your purposes and for evidence-based practice purposes, qualitative research really probably isn't going to help you much, okay? I'm not supposed to say that because that really offended him, but I'm not saying there's not a place in the world for qualitative research. A lot of times qualitative research will drive quantitative research. Because a lot of times the thing is, if you don't sit there and listen to people's stories, you don't know what questions to ask, right? You could automatically assume that if you're going to deal with a homeless population and you wanted to ask them about their medications and their whatever else, and really the biggest thing on their mind is food or shelter or something, unless you ask those questions, open-ended questions, and get qualitative data from people, do a qualitative study, look at themes, listen to all those tapes, you know, find the themes, and then develop a quantitative tool based on all of those themes. I mean, that's perfectly useful. But for your purposes and looking for evidence, qualitative studies are probably not going to be very helpful to you at all. So, evidence-based practice in an organizational context. Knowledge-focused triggers are those that begin with an innovation or research finding, maybe like journal club. You know, I'm a fan of journal club. A lot of people don't like doing it because they think it's a lot of work, but I think it's good because I think it's an opportunity to get you to start thinking about and reading things and looking at things from different perspectives. It's never going to hurt you to be someone who can say, well, you know, I read in so-and-so, so-and-so, well, and even you've got smart ass too, right, doing that, but you know, like I find myself sometimes in philosophical discussions with some of the anesthesiologists at Mayo, because they'll say something and I'll say, well, you know, there was a study done last year by so-and-so, so-and-so that talks about, you know, that really says that there's a better way to do this, you know, or whatever. It doesn't hurt to be smart, right? Never hurts to be smart. As opposed to problem-focused triggers are usually clinical situation driven. I find among this group, it's going to be much more knowledge than problem-focused triggers. It's going to be more looking for a better way to do things, even though the way that they're doing it now works, right? In an evidence-based practice appraisal, you're going to, part of the appraisal is the implementation potential. And implementation potential doesn't mean anything other than your how feasible and the cost-benefit ratio of things. Like I said already once, if it's going to cost the place money, it may be a little bit harder of a sell. Like, for example, let's say that whole project that I was telling you about hypothermia, they didn't already own all of those patient-controlled warmer on the pole things, and they didn't already own all of those gowns that nobody uses and all that stuff. And you walk in and you say, hey, you know, if you pre-warm people, they do a lot better. And so this is my proposal, but you're going to have to go out and buy these 70, you know, warmers and all of this stuff and equipment and whatever. And they'll be like, yeah, we'll just leave them cold. They'll be all right. Now, the one caveat of that study is that after 2 hours, the pre-warming pretty much is useless. It doesn't mean anything because within that 2-hour period of time, you're going to catch up using whatever OR warmers that you're using. You're going to catch up for anything that they lost preoperatively. At Mayo, that's a little bit problematic because you probably couldn't get a manicure under anesthesia in less than 3 hours. So pedicure maybe, I don't know. So I have seen, well, I have done 6.5-hour long lap choles. I could tell you. So.
Lap choles are 3 hours.
3 hours minimum. So, but it's a teaching hospital, right? Everybody's there to learn.
So prep is a separate procedure. You have to use all the prep because of infections.
So, but you know, there's not a lot of research out there about length of surgery and infection rates. And I'm lying because there really is. Really, there's a direct correlation between length of surgery and infection rate, but that doesn't seem to stop them from taking forever. 3.5 hours. I get 2 of them done before I get relieved for the day. So
that's a nice day.
where we pull the feet up, you know, I got, you know.
Kill that.
Not a man. You pull that cell phone out. Pull that cell phone out. You're going to the principal's office.
Somebody's coming for you.
Yeah. So, although everybody does, I see people all the time. So, as we get into this course and we start talking about some of those research building blocks before we get into a lot of the evidence-based practice stuff, we're going to build on that knowledge that you have, the stuff that we cover. We'll get to the point where we will get into the Melnick book at some point, and we'll start talking a lot more about evidence-based practice. Now, next, I'm not trying to put the cart before the horse here, but next semester, you guys have that role transition course, whatever that's supposed to be. I usually try to keep up with y'all in that course, even though I don't teach that course, about project ideas and things that, so when we do get to evidence-based practice 1 next summer, that maybe there's at least an idea there of something that you might be interested in. It never hurts to ask at the clinical sites. I would just, as a friendly request, ask that you really try to avoid Flagler for trying to implement change. They are very research focused there, Dr. Gimmel and his group there, and I just, and one of our graduates from here who I went toe-to-toe with when she got her DNP because she kept trying to do research and I wouldn't let her, and so needless to say, after the, I don't know how many different row her and I got into over stuff, she's not exactly my biggest fan, but she did what I made her do, so she did what I told her she had to do. whether she liked it or not. They constantly are sneaking in ways to try to turn your EBP project into research and then making you feel bad about not doing it the way they want it. So if you go to Flagler, enjoy the rotation, enjoy doing anesthesia there. It's not fertile ground to do an evidence-based practice project by any stretch of the imagination. They are very research focused, and they will try to their damnedest to get you to turn it into a research project, and then it'll be between them. You'll be between them and me, right? Because I'm not gonna let you do it. so I would stick with the big players: Mayo, Halifax, UF Health. You're not at Tampa for a long enough period of time to make a big difference with anything down there, so I probably would try. I think it's just easier to stick with places around here. Plus, by the time you guys get to that point, we'll probably have Memorial. I'm sure Memorial could probably use all the help they can get. That's my outside voice. But it's a change. You know, everything is a continuum. Life changes, everything changes, and they're making a change for the better. Things are moving in a positive direction there. So, because I don't know, the history around here, but for many, many, many years, Baptist South, Memorial were all physician anesthesia. They didn't have any CRAs, they didn't have A's, it was all just docs doing cases. Well, the unfortunate thing about that is for many, many years, hospitals, when they made money, could pay stipends to anesthesia groups. And those stipends were needed in order to make up salary gaps between reimbursement and salary structure of the group. Anesthesiologists make a lot of money, right? On average, they probably make about $350,000 a year. And they don't make anywhere near that amount of money in reimbursement when they do their own cases. So the hospitals would subsidize them, right, with these stipends, they call it. Well, over the years, money gets tighter, money gets tighter, money gets tighter, money gets tighter. The hospitals start saying, that $10 million we gave you last year, we're only going to be able to give you $8 million this year. Because it was like $400,000 per operating location or so was the average in Florida 5-10 years ago of stipends. So then next year it's like, that 8 we gave you this year, we're only going to be able to give you 6 next year. We're going to 4, okay, and then, so the reason why groups like Sheridan and Team Health, I'm blocking, Mednax, US Anesthesia Partners, why they've spread like cancer around the anesthesia community is because what they'll do is when people are doing the RFPs, where they're looking for bids for the anesthesia contracts, they'll come in and they'll say, we can do it without a stipend. And they'll be like, what? You could do it without the $5 million a year I've been paying Dr. Dingleberry and his group? I don't have to pay you that $5 million a year and you're still going to provide all my needs? Yeah. Where do I sign? Right? Now all of a sudden, Sheridan's there, right? And you're not, or your docs are not, or they might be, or some of them might be, some of them might not be, and things change. That's how they do that. Well, you know how they do that is because they use a medically directed model. Okay, ACT or anesthesia care team is an American Association of Anesthesiologists term. That's an ASA term. That's like when you say someone's ASA score, it's not. It's their physical score, even their PS, whatever. It's what they are. If you say ACT, then you're buying into the American Society of Anesthesiologists' definition of the anesthesia care team. It's medically directed anesthesia, right? We're medically directed. We're not supervised. It's medically directed. I have a license, right? So, under medical direction, especially if you can maximize medical direction to Medicare and Medicaid rules, which is 4-to-1, you save money. Because you're not going to pay a CRNA $350,000 a year, right? Now, those jobs are out there, right? And you're going to go through gas work because that's going to be your therapy, is looking at gas work for jobs to remind yourself, what the hell am I doing, right? Why am I doing this to myself? So, don't lie, you've been on gas work. So, don't go to Gas Works with an S though, because that's a porn site. Gas Work, just work, W-O-R-K, period, right? GasWork.com. So, and then people are going to be wondering about your browser history. It's one of those things, if I ever drop dead, somebody delete my browser history kind of thing, Anyway, so these groups come in and they underbid everybody, and because they used a medically model with AAs and CRNAs, or CRNAs and AAs or whatever in Florida, And they make money that way. So eventually Baptist South, which was the same group, and Memorial had to cave to a medically directed model for money, for the money reasons. Right? So it's good for us. It's positive for us, right? It's more jobs for us. So, but we have to be the ones, and you are going to be the ones who have to drive that ship, right? You have to understand what your value is, and not, you got to quit acting like a nurse, basically, right? Yes, I'll take less money. Yes, I'll whatever. Yes, I'll do whatever. Yes, I'll work overtime for nothing. Yes, no. There's value. You got to pay for that. Stuff costs money. But you're going to see those $350,000 jobs in gas work, and they don't pay you $350,000 a year because you're cute, or because they think you're smart, right? Because they're going to work $350,000 out of you every year, right? The reason why it costs that, they're paying that much is because that's how much it costs to get anybody to stay there, right? They're not paying that amount. So that's something also to keep in mind is you want to balance. There's got to be work-life balance, even though I know those loans are. Because my anesthesia program costs $1,500, like 1500.00. So, and I got paid $150 a month while I was there. So, times have changed. Anyway, so, but I know you got loans, you got stuff to pay, but keep in mind the fact that you also need to keep your sanity too. In that first job, the average CRNA stays in their first job about 2 years or so. So even though you may think it's your dream job, the research shows it probably isn't. So, but anyway.
Do you have any thoughts on first jobs? I mean, because I'm not staying in Florida, so I have the option of not going with an ACT model. So,
You don't have to do that necessarily. I mean, there are people who come out and go into more independent type situations. But with that comes a lot of risk too. I mean, experience is a great equalizer when it comes to stuff like that. My first job out of anesthesia school was on active duty in the Air Force, and I went to Seymour Johnson Air Force Base in Goldsboro, North Carolina. First off, Seymour Johnson is pretty funny. So, there's not much culture. Tobacco fields, Wilbur's, not much, not a lot of culture. So I was there for 4 years in Goldsboro. I worked at a little 20-bed hospital that had 2 OBGYN docs and 2 general surgeons. No MDA, there was no anesthesiologist, there was just 2 CRNAs. The guy, when I got there, he'd been there by himself for a month, and he was tired. I walked in the door as a brand new grad. He handed me the keys and paper and said, "I'll see you in a week." So that was sink or swim, Did I do everything right? Probably not. Did anybody die? No. But, scary. Some scary stuff. I kind of think for the first year or so, it's probably good to get some level of backup available.
So what I would say is like Halifax is unique in the clinical experience that you guys will have in Florida. Now Habersham and Georgia is a little different because you've got CRNAs that are up there that are running. Halifax is billed as a QZ model, which means we're not directed or managed. They come in, the anesthesiologists come in at induction, and we don't see them anymore. That's it. It's the only time we see them. So you have the chance to do your thing, right? To learn as a student when you're in the student role, but as a new graduate, that's where I started after I graduated. I got good at what I was doing because I was forced to do it by myself. But I always had hey, can you come in here? That was very handy in case I got into trouble, because you're going to get into trouble when you graduate. It's going to happen. You'll learn more after you graduate than you did during school, because you're forced to make decisions. You don't get to look over your shoulder and go, "What do you think about?" Right? If you work with me and you go, "What do you think about?" My statement to you is going to be, whatever you want to do.
As opposed to Charlie Roop, who was one of my clinical instructors in anesthesia school, when you look at him and say, "Hey, you're the one who's, this chicken, I'm just holding its legs."
Yeah. Whatever you want to do. And the reason that I do that is because you guys if I coddle you, because that's what it is, I'm not helping you.
Right.
Because if you go out and every time you look over your shoulder and say, is this okay? Should I give this neostigmine? Does the patient need neostigmine? Well, do you think they need neostigmine? I don't give a shit if you give them neostigmine or not. Do they need it or do they not need it? Did you check twitches? Did you not check twitches? How long have we been in the case? What do you know about the patient? You need to make these choices. I know what the patient needs. I know what I would do based on my experience. I need you guys to know that, right? So you're going to work at other clinical sites where everything you do. What are you doing? Stop. That drug, 2 cc, 1 or 2 cc. That's it. They're going to tell you exactly what to do, right? That's not learning.
No.
That's not learning. So when you graduate, to be in it, if your experience has been someone telling you what to do every time, where's your decision making been built in that over your course of training? It's not. That 12 to 18 to 24 months after you graduate, no one's looking over your shoulder. No one's telling you what to do. You are on your own. And some people struggle mightily.
I can tell you that someone who recently graduated from this program, actually someone who, alumni of my anesthesia program who I've known for years, owns a private anesthesia group, and this person went to work for him as a new grad, and although this person did really well as a student here, it was a critical access hospital type situation, and they have struggled mightily to the point where he pulled that person from that particular place and put them in one of his surgery centers he staffs where there's other CRNAs, which is unfortunately a 30-mile drive each way for this person, but they just weren't making the right decisions at that little critical access hospital when they were there by themselves.
And you have to, yeah.
Right.
It's not like, I mean, we only had 2 CRNAs at ours in Wisconsin,
So
that's all you have.
Autonomy is bittersweet.
It is very much so.
Right? I want autonomy. You all came in when you sat in front of us, and I want to be in this program. Why? Autonomy.
Yeah.
Right? You all had the autonomy flag.
I don't want to be a nurse anymore.
I don't want autonomy. The problem is when you get it, then you look around and you go, I don't want this at all. This is not what I signed up for.
So now, if you take that whole thing and you go 180 degrees and you look at it from my perspective at my age and my point in my career, I work at Mayo, okay? Smothering, suffocating medical direction at Mayo. Up your backside, down one leg, and whatever else all the time, depending on the doc, right? Depends on who it is. For me, sexist is, you know what, that I'm an old guy, most of them are old guys, they leave me alone. They stay out of my room, they don't come. The younger ones, they're all over it all the time, doing all kinds of stuff. So I'll tell them what to do, whatever, blah, 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 blah. Some people like that, some people don't. It doesn't bother me. My thought process. Let's say I'm at the end of an anesthetic, and I've got a patient that's intubated, and they're reversed, I've checked their twitches, they've got sustained tetanus, I'm at 0.1 end-tidal SIBO, and they're just really not doing a lot. And I'm like, hey, Bessie, can you open your eyes for me? Tube's there, maybe pulling 200 cc tidal, right, or so, right? So now, I make the decision, and I extubate the patient, and I take them to PACU, and they end up getting reintubated. Guess what? That happened because I'm a stupid nurse and I don't know what I'm doing. I call on my little phone, my little back phone, right? Hey, Dr. So-and-so, give me a minute. I just pull the tube. Okay, I pull the tube. Go to PACU. She gets reintubated. Now it's become an unexpected anesthetic complication. Because when they say, why'd you pull the tube? I can say, I know how to play the game. Now, me making that independent decision to pull the tube or calling him to pull the tube, they don't deduct money from my pay for making phone calls. They don't charge me for the phone that's on my hip, right? So I'm not going to get paid any more for making those independent decisions. I'm not. I don't get paid to do that. I don't get a bonus for not calling the anesthesiologist. Right? They're making more money than me, right? So you have to understand it from my perspective now. That's the game I play, right? Because if you know the game, the rules to the games are easy to play if you know the rules. If you memorize the rules, they're super easy to play. And so I never have any strife, I never have any problems, I never have any questions or issues because I know the rules of the game and I know how to play it, right? So I used to be there was a point in my life back when I was younger where they would say, oh, well, yeah, we don't let the CRNAs here do regional anesthesia, the docs do all the spinals. And I was like, that's the dumbest thing I ever heard in my life. I did like 1 million spinals when I was in the Air Force. I could probably put a fine CSF in a turnip if you asked me to, you know? And so I'm like, but then I got to the point, it's like, okay, so let me think about this one. I'm gonna go stand here and watch you work and you're still gonna pay me the same amount of money as if I did the work. Okay, you know. Now, I'm saying you gotta get the experience, you gotta know how to do it, you gotta know what you're doing and all that other stuff, but so you're gonna pay me to watch you work? Nice, I love it, you know? I don't care. At this point, I don't care. But you need to care, obviously, at some point in your career. But you got to learn to play the game, the rules of the game where you play. And, you know, in some places, there are more comfort zone than other places, right?
So back to your statement about pulling the 200 title volumes. Are you calling the MDA because of pressure constraints to get all the rooms so they'll turn it over for the next case?
Not at Mayo.
Oh, okay.
No. No, there's no pressure constraint there. Now at Halifax, they're probably going to be up here. If your wake up's taking more than 2 minutes, they're going to be all over you, like, you know.
Yeah, I mean, we definitely have the cases moving a little bit quicker, but
Yeah.
it's, you call, if there's something, when you're assessing the patient and you just have that, something's telling you,
You're not ready.
you know.
That nursing intuition.
You know, I don't know,
Because we care.
right? So if you have that, something's in the back of your mind, that intuition, you should call somebody else. Just get a second opinion.
Mm-hmm.
It's not, doesn't hurt my feelings. I call now.
Yeah.
I had a case this week where we were in a GI case. I was with a student, patient laryngospasm. We tried to handle it. The patient desatted. As they were desatting, I'm pushing propofol and sucks, and I'm having someone else call the anesthesiologist. The anesthesiologist comes in, we're intubating as the anesthesiologist is coming in. It's not that we didn't continue doing what we knew we needed to do, but they signed it on the case too, right? So I shouldn't get to the end of the case and go, hey, by the way, sat went down to 42, and then, you know,
Right.
we gave propofol sucks. The SAT was 11, and then we got the tube in.
There's your, yeah, and
Right.
and now you completely wrecked the trust issue with that anesthesiologist probably for the next year.
Yeah. So
Yeah, I'm the same way. I call him and I'll say, I know exactly what to do. I had a student in with me in that disaster case, and I had given enough crystalloid, and I said, I don't want to give this guy any more crystalloid, and, you know, I'm still having issues here. He's not making pee, enough pee to make me happy, whatever. I said, you know, I've given albumin, but, you know, it's Mayo, so I got to, of course, obviously call to get Mayo. So I said, students up, you know, if it was up to me, I'd just give him some albumin, and the anesthesiologist walks in and says, why don't you give him a bottle of albumin? I was like, okay. I knew what to do, you know, I'm not gonna breach the rules, you know, sorts. Now, I'm not gonna call him for ephedrine or neosynephrine or something. There's one anesthesiologist there who gets mad at you if you give phenylephrine and don't call him and tell him. But I told him, well, if you have a problem with it, then change the protocols. Because protocols say I can do it, I don't have to call you. So, starts with a P. First name starts with a P too. Yeah.
Do you have any models in our clinical sites that use the induction rooms that we were reading about? Okay.
This went away when I was in.
Well,
We used them when I was in
one of the
anesthesia school.
readings, it
but-
sounded like it was coming back for the pressure constraints, you know, that you experience in
That
other
was-
hospitals.
What about in the UK?
That would seem odd.
well, I mean, it's
Actually,
Get in
the
and
city, are we doing the group 2?
It's the one that says social and it should be, that sounds
It
right.
asks us if we want to
Social
sign up for CME CEUs for it, should we select yes for it?
You don't need CUs.
Okay.
So for the state of Florida's purposes, other than your mandatory stuff that you are required to do for your license, like if you're required to do, so you are not nationally board certified as an ARNP right now. So once you are, you can, a lot of this stuff doesn't pertain to you. Like the opioid one did, like we all had to do a 3-hour opioid prescriptive, whatever, controlled substance prescriptive opiate something or other class. But the stuff like domestic violence and HIV and all that stuff, once you're board certified by a national certifying agency, you don't have to do any of those anymore. But as an RN, which is your role here, you still have to go. So that stuff you have to do. As far as your 25 CEUs you need every year, any class that NUR anything pretty much is a 3-hour class is worth, is it 45?
Yeah.
Something like that. So one course that you took will cover your CEU requirements for Florida license for the 2-year biennium. So as far as CEUs are concerned, no, you don't need CEUs. If any of you are CCRN and planning on keeping that, you can use a certain percentage of your credits can be your coursework here. But there is some other stuff that you have to do to keep that. Once you graduate and you're certified, I personally don't see any reason to keep it, but that's up to you. If you wanted to keep it, that would be your thing. That's really not going to do anything for you as a CRNA. Yeah, I got a conference call at 11 o'clock. I forgot about. I guess I gotta walk back there. With the VA Bay Pines. So, not for you. It's not for you, it's for the ARPs.
No.
No, it's for the ARP, it's not for anesthesia. No, anesthesia in the VA is really interesting, so. But the only one around here is Gainesville and Lake City. No point in it.
The VA that I worked at had a 1-to-1 ratio of anesthesiologists to CRNAs. So every room has CRNA with an anesthesiologist overseeing.
Mayo does a lot of 2-to-1, 3-to-1. It's never 4-to-1 at Mayo. The worst it ever is 3-to-1 to an anesthesiologist. It's 2-to-1 most of the time. But like I say, for me, they're there for induction, and I don't see any until time to wake up because they have to sign the chart on the workers. So. All right, so like I said, it won't take, this class never takes me the whole 3 hours, so I'm gonna leave it up to you. I'll be here next week. If you wanna come and knock that thing out here in class, if you wanna do it on your own personal time, I don't really care. But we're gonna get that city thing done. I'm not gonna be any lecture next week, so we're gonna get that city, I gotta get that taken care of. That's got to be, you gotta have that because in the HSR determination form, which is the human subjects research determination forms that you're gonna do any evidence-based practice to get the IRB waiver, on that form it says, have you had city training, have you completed city training? You have to check the yes box or they won't accept it. So even though we're asking for a exempt from review, what we're saying is we're sending them this paper and we're saying, hey, look, we're doing evidence-based practice. We're not doing research, right? Research means that I'm trying to see whether or not this is going to work. Evidence-based practice means I got a whole ton of crap here that says that this works, and we're just going to make it happen, right? So there's no consent in evidence-based practice, right? We don't consent people. You don't need to consent. There's not an equal chance of harm or helping them as research can be. If it's a new drug investigation, and I give it to them and they grow like, purple horns or something, and I didn't know that before the study, was concerned, yeah, I mean, that's a problem. In evidence-based practice, we already know. I'm coming up. Yeah, I know, that's 11 o'clock, yeah.
Okay.
So,
I thought you were finishing up. I was gonna say.
yeah. So there's no, this is evidence-based practice. This is not research. We're not researching. We're taking a ton of already known knowledge and we're putting it into practice, right? It's not research. There's no consent requirement. So there's no IRB requirement, so to speak. Now, the IRB still has to say that they don't need to review it. So that's what I'm going to do city training next week.
Okay.
Because then it's done, and I added it to the course.
Perfect.
Because I ran into students last time who hadn't done it, who then had to sit down and try to carve out 3 or 4 hours of their time to do their city training before they could turn in their IRB forms. So we're just going to knock it out in this class. Everybody will have it. It'll be done. Good idea?
Good idea.
Right. So, because Megan's probably
Does it last 3 years or 2?
3.
I thought so.
But they'll be out of here before it expires. So anytime.